although it is challenging to talk about atypical diabetes in 20 minutes. These are my disclosures, and you can see that I've been asked to speak on 3 areas of diabetes. First 2 are not perhaps as well known as they should be, but the third, type 2 diabetes in youth, I've only got 7 minutes to talk on it, and it's probably the most important condition in the world, but particularly in India. And I hope there'll be an opportunity for this in this meeting to discuss what will be one of the biggest challenges to this country in the coming years. But let's start with cystic fibrosis diabetes. The related diabetes to CF is a very common morbidity. Around the US, 30,000 individuals, 50% who are children, are diagnosed with CF in the US. And there are around 17,000 and 4,600 cases of CFRD in children and adults, respectively. Around a third of women with CF without diabetes develop gestational diabetes. And the risk of diabetes is, of course, increased by glucocorticoids or other factors associated with their pulmonary disease. And lung transplant recipients, of course, a treatment for some who are using immunosuppressives are also at high risk. And there are differences which I will go over, and it's therefore a unique presentation and an approach to diagnosis and management. You can see that the prevalence of related diabetes in CF goes up in both sexes, a little more prominent in women in their childbearing years, perhaps unsurprisingly, but otherwise the prevalence is the same. And you can see for those who live into their 20s and 30s and 40s, and of course that is the difference. People with cystic fibrosis used to die in adolescence, but over the last 20 years they survive and then they get their diabetes. The characteristics of the 3 conditions, type 1, type 2, and CF related diabetes, are shown on this slide. I think the important things are that exocrine deficiency is present in cystic fibrosis disease. It rarely causes ketoacidosis because there's always some insulin around which switches off ketogenesis in the liver. Importantly, just a little bit of insulin will prevent DKA because the ketogenesis pathway is uniquely sensitive to insulin, and the risk of microvascular complications is less, but only because they rarely have severe disease. Insulin is the treatment, and the other difference is that it needs a high-calorie, well-balanced diet. These individuals tend to be underweight. So it's the reduced beta cell mass leading to insulin insufficiency, which is essentially present. The mechanisms may be due to oxidative stress leading to beta cell damage, a dysfunctional CF membrane, conductance regulator, a protein, and importantly, collateral loss of islets as the exocrine pancreas is destroyed. And there is some suggestion, and I'm not an expert, that the CF chloride channel defect itself, responsible for cystic fibrosis, may lead to susceptibility damage in beta cells. And the insulin resistance caused by medications, but also inflammation and chest infection itself, may also be relevant. So the management is summarized as this: screen from age 10, used to be GTT, but I suspect, at least in some countries, continuous glucose monitoring may replace that, certainly HbA1c. Very importantly, it needs a multidisciplinary team, MDT, with expertise. And luckily for us in my hospital, the cystic fibrosis unit is the floor above the diabetes unit. So we run a joint clinic with our respiratory medical colleagues, and the nurses are expert in both, and importantly can focus on self-management education for the people. We run structured education courses for people with type 1, but also cystic fibrosis. And the insulin is good for stabilizing lung function and improving nutritional status. Recommendations are different from those in type 1 and type 2. So the diet needs dietitians with expertise, high calorie, high salt, high fat diet. And we do teach carb counting to all our patients on multiple insulin injections and pumps. And it's important in this condition. So those with diabetes have a worse prognosis than those without. Ketoacidosis is rare, severe hypoglycemia is uncommon, and the risk of micro and indeed macrovascular complications is not high. But these patients rarely live into their 70s, although that's beginning to change, which is why they may not get microvascular disease. But early diagnosis is important for nutrition, lung disease itself, and survival. So let's turn to diabetes due to pancreatitis and pancreatectomy, also known as type 3C. Recent data suggests the prevalence is getting higher, 5 to 10%. It comprises approximately 75% of the non-type 1, type 2, at least in Western countries. I don't know if that's the case here. In established chronic pancreatitis, you can see diabetes prevalence is pretty common, between 25% and 80%, depending on duration and severity. And new advances in beta cell biology had found new etiologies, and I'm going to mention a couple of those, including one particularly common in this country. So this is the pathophysiology. It's unique, it's different, very different, even from type 1 diabetes. It's insulin deficiency, loss of pancreatic polypeptide, and hepatic insulin resistance. And where the pancreatic head has been lost or damaged due to trauma, complete or surgical removal, or chronic fibrosis, then these individuals are predisposed to PP deficiency and subsequent insulin resistance, which can make it challenging. We're always, importantly for somebody like me who's interested in hypoglycemia, the alpha cells are damaged at the same time, so that makes these patients prone to hypoglycemia, impaired other peptides, important. The body's own GLP-1 has impaired production, and I'm sure that contributes to the phenotype. And so this combination of islet cell destruction, insulin resistance, and co-regulatory hormones produces this very complex endocrine phenotype, and that makes its management very challenging. So you might say, well, what do you do that's different? The importance is to make sure that nutrition is a focus, and so it's important that your nutritionists or your dietitians, as we call them in the UK, are trained to look at that, and importantly, they have to replace the exocrine pancreas with the relevant enzymes. So these patients should be on supplements, and again, a joint multidisciplinary clinic with expertise in those who can treat the malnutrition as well as the diabetes are important. That doesn't happen. Let me tell you about fibrocalculous pancreatic diabetes. It's confined to tropical regions and southern India, the state of Kerala has the highest prevalence in the world. I don't know, there's people in this audience who are probably more expert than me. So the typical patient is lean, young adult, malnourished from poor socioeconomic background, recurrent bouts of pain and steatorrhea, and characteristically, X-rays or ultrasonography are diagnostic in demonstrating a large number of discrete pancreatic calculi. It's possibly due to genetic, nutritional, inflammatory factors. The pathogenesis is not well understood. Diabetes is challenging. I've never seen a case. I'd be very interested to know whether anybody in the audience has seen that case. Often difficult to control. DK is rare, but you usually need insulin. And the other thing is they get a lot of pain and they may need surgical removal of these pancreatic calculi. Microvascular complications common, macrovascular disease rare, and pancreatic malignancy is increased, and as we know, a feared and recognized complication, which is often fatal. And I want to finish off by talking about genetic pancreatitis. So quite a few people with pancreatic diabetes have underlying genetic causes, cause hereditary genetic pancreatitis, and they have characteristics, mutations in what is called the cationic trypsinogen gene. Don't ask me about it because I am not expert, but you can see that 80% of patients with hereditary pancreatitis have this. And again, these patients are at risk of cancer, and so the treatment is actually pancreatectomy and auto-islet transfusion. And if you look at the success of this treatment, you can see that the majority are either insulin independent in pale blue or have minimal insulin use. So this is a successful treatment, although of course it needs specialist centers who can do it, but it appears to be the treatment of choice in severe pancreatic diabetes. But I want to finish off by talking about this condition. For those of you who don't think this is important, this is going to dominate your management in years to come. I guarantee it. It is very frightening, and I hope the slides that I've got will briefly show you how important it is. It is going to become, in my view, the most important type of diabetes, particularly in this country, in years to come. There's a rising epidemic in the US, and you can see those who are most affected are indigenous population, American Indians, so-called, non-Hispanic blacks, and Hispanic. And look at the curve for the non-Hispanic white, right at the bottom in green, barely increasing, but even they have a scary time. Here's the global prevalence of type 2 diabetes, and you can see in Europe, right at the top, it's pretty unusual, or was, with a prevalence of 1 per 100,000 back in 2021, but it's increasing. Let's go down to the bottom. Brazil. India is not in this curve, but I looked up just earlier in the last few days where the epidemiology is in this country, and it's exactly the same as Brazil. That is 1,000 times higher than in Europe. And a recent paper in this country from Bengaluru showed that in adolescent individuals in this country, the prevalence of either pre or early type 2 diabetes is 10%. 10% of your adolescent population have early diabetes, and that is 1,000 times higher. So 10% of the Indian population multiplied is a lot of people. And not only that, the prognosis of these individuals much worse than type 1 diabetes. So Brazil is the maximum and India is way up there. And it's the same pathophysiology, except probably pubertal insulin resistance, but we don't know why it's suddenly becoming so common. But these are the factors which are causing type 2 diabetes, but at a much earlier age, particularly loss of beta cells already in the teenagers. And as we were actually discussing in another meeting earlier today, they're going to disappear, and already this is causing microvascular disease. So let's look at treatment. This is an old study done in the US, 2004 to 2011, 700 patients. They used metformin and lifestyle, metformin with Rosie, and metformin and lifestyle. And treatment failure was an A1C above 8%. After half those patients on metformin had an A1C which was less on monotherapy. Rosiglitazone and lifestyle made no difference, and a third had egregious by greater than 0.5%, but a fifth had an increase in A1C. Let's fast forward, and what I want you to look at is these curves on the left, and on the right, as they were followed up in observational study as the years, the numbers with an A1C which was high went up, and then was approaching 50%, above 10% at the end of the study. And look at the incidence of hypertension, nearly 75%, kidney disease, 50%. These people will get renal failure and will need dialysis and kidney transplantation, and they will die. Neuropathy was also prominent here, and the chances of avoiding major complications was very low indeed, just 25%. At the age of 25, 80% of these people have complications, and if that isn't scary, I don't know what is. Look at the differences between type 1 diabetes in black and type 2 diabetes in young people in red. And you can see how scary that is. And what are the treatment options? Well, at the moment, the FDA in the US has approved metformin, insulin, and one GLP-1 agonist, but it's not, I think it's dulaglutide. It is not the most effective drugs. And SGLT2 inhibitors are not improved, yet they protect young people from kidney disease. Metabolic bariatric surgery is useful. Medical therapy for both glycemic and non-glycemic outcomes is clearly possible. And there are studies to show that you can have a greater regression and attenuation of kidney disease with medical treatment, aggressive lipid, and glucose lowering. So, what's the model? Primary care screening needs to start. I don't know whether it is in this country, but it's essential. These people need referral to a pediatric specialist clinic. They need a multidisciplinary clinic. Lifestyle management, frankly, has shown to be ineffective, but what else do we have? And we urgently need to know what therapies are most effective, because we just don't know, although probably GL1 receptor agonists will be transformational, and I can give you anecdotal reports. So the conclusions are, this condition is a unique challenge to all countries, but particular to South Asia. Comorbidities develop rapidly. While the key intervention is lifestyle change, it's shown to be almost totally ineffective. Aggressive insulin treatment is probably the wrong treatment. It increases weight, it will be resisted by teenagers, and it isn't actually what we need. Clearly, GLP-1 agonists are potential, but the number of studies are very small, and we urgently need studies, and I would suggest humbly that this country is exactly the place where that should be done. But we definitely need much more research, and we need an answer quickly, or these kids will die with horrible complications. And with that, I'd like to thank you for your attention.